Thank you for joining us today. I'm Dr. Kevin Tucker from Harvard Medical School. We have just a few housekeeping details to share before we get started. This program is being recorded, and the link for the video will be available within a few days. The recording will be shared by email, and it will be posted on our website. Continuing education credits will be available. When today's webinar concludes, participants may click on the evaluation link in the description below this video window to obtain continuing education credits. We're delighted today to be joined by Dr. Joe Betancourt. Dr. Betancourt is Senior Vice President for Equity and Community Health at Massachusetts General Hospital. He's the founder, senior advisor, and faculty to the Disparities Solution Center at MGH. He's faculty at the Mongan Institute and an associate professor of medicine at Harvard Medical School, as well as a practicing internal medicine physician. Dr. Betancourt is a nationally and internationally recognized expert in health policy, healthcare disparities, diversity, and cross-cultural medicine. He received his Bachelor of Science degree from the University of Maryland, his medical degree from Rutgers, New Jersey Medical School, and he completed his residency in internal medicine at the New York Hospital Cornell Medical Center. Following residency, he completed the Commonwealth Fund Harvard University Fellowship in Minority Health Policy, and he received his master's degree in public health from the Harvard School of Public Health. We're delighted that Dr. Betancourt is able to join us today for our webinar series on healthcare disparities.
Thank you so much for that kind introduction. It's a real pleasure to be here with you all today and to humbly share work that is near and dear to my heart, certainly work that I'm very committed to. Again, just by way of background, I'm a primary care physician. I see patients here at Mass General, been here for about 20 years, been part of our Center for Diversity and Inclusion over that time, and now get the privilege and honor of leading our equity and community health work. And that's what brings me here to you today, the opportunity to really talk a bit about what we've learned and what's transpired as a result of the dual pandemics that people often refer to, COVID-19 and racism, and our path towards structural equity. I'll also just mention that this work is personal to me. I'm originally from Puerto Rico, grew up in a bilingual, bicultural home, really got a chance to experience a lot of the things that my work provides oversight for here now myself personally. And so for me, this opportunity to do work in this area is a privilege, and it really is personal and meaningful to me. So it's with that introduction that I'm going to begin. And I'm going to begin by first starting out with a bit of an overview of where I hope to take our conversation today. So first, what I'd like to do is provide an overview of the conversation and talk a bit about this concept of disparities and equity. And I want to kind of break it into a couple of different chapters, kind of pre-pandemic, kind of really, March of 2020, pandemic, post-pandemic, and then post the murder of George Floyd, which really certainly led our nation to a long overdue reckoning, national reckoning on racism. But I want to break it up into three chapters. As somebody who's been committed to this work my entire career, this has been, I think what I'd call this last year, the best of times and the worst of times. It's been the worst of times for all the reasons that I'm going to be sharing with you today. This pandemic disproportionately impacted communities of color. The issues related to race and racism, I think, came to a head like never before, certainly in my lifetime. And it was difficult. It was challenging. It was taxing physically, emotionally, spiritually. In so many ways, it took a toll on all of us. Those were the worst of times. But it was also the best of times. It was the best of times because many of us really responded to the call, answered the call, responded to the urgency of now, stood up and took action. And my hope is that we have the courage to learn the lessons to take the lessons that we've learned with the pandemic and post the murder of George Floyd to a better, more just, and more equitable society, healthcare system, and as we deploy our community health strategies. So I think clearly this time is a time that allows us to perceive a new future. And it was also the best of times because for a lot of years, I've spent my time, and many of my colleagues have spent their time really making the case for why we needed to address disparities in equity, building the business case, the quality case, the safety case, in any ways, using a variety of different angles, quite frankly, to get leaders to buy into the importance of addressing disparities. And so what's transpired over the last year has become a global case study for why we need to be more attentive to the needs of diverse populations, both locally, nationally, and globally, and its impact economically and otherwise when we are inattentive to these issues. The importance of funding and investing in public health, the importance of addressing structural racism in our nation and our society. And the best of times became that because so many more people understood this in ways that were more meaningful and deeper than ever before. So the outline for today is to provide a bit of the backdrop of where were we around disparities and equity before March of 2020 when the pandemic hit. What were we up to? What were we doing? Where were we? And then kind of the pivot. COVID-19 happens, George Floyd happens, and what are the lessons learned and ways that we've tried to animate, execute, create new strategies, having the courage again to take those lessons we've learned and give us an opportunity for a better future. So I want to begin with one data slide. This is the data slide that I was showing people pre-pandemic, telling them about this issue of disparities in health, racial and ethnic disparities in health, disparities being a simple concept, differences between groups on a certain measure, disparities in health, particularly being able to be stratified, looking at disparities by a variety of different characteristics. We could look at health outcomes and stratify by race, ethnicity. We could stratify by socioeconomic status, by gender, by disability. My work has principally centered on racial and ethnic disparities in health and healthcare. And so this slide gives us a bird's eye view at, for example, one of our nation's largest killers, diabetes, and gives us the diabetes-related death rate per 100,000 population in 2018. And so in disparities work, we benchmark against the majority population. This is data from the U.S. Department of Health and Human Services using a very high-level categorization of race ethnicity. So we see white, Black, Hispanic, Latino, American Indian, Alaska Native, and Asian Pacific Islander. And so when benchmarked against the majority population, you see that certain populations, Black, Hispanic, Latino, American Indian, Alaska Native, tend to do less well than their majority counterparts as it relates to diabetes, with Asian Pacific Islanders doing a little bit better per this data. So I'd say a couple of things about this slide. We probably know the most about Black-white differences in the United States because of the way we've collected our health statistics using two categories, Black, white, non-white, or white, Black, and other. And so we are learning a lot more about disparities and how they impact other populations. The second thing I'd say is that, as you look at these categories, Black, for instance, there's incredible diversity in that category. This could be representing individuals who are African-American, who've been here for several generations, recent immigrants from the African continent, or individuals of African descent from the Caribbean. The same could be said for every one of these bars, incredible diversity within each one of these bars. So this gives us a bird's eye view, a 30,000-foot look to help define this issue of disparities. But certainly our ability to intervene locally does require that we go into subgroups and get local diversity and better understand our local communities. That becomes the foundation for interventions that we aim to deploy. And again, these big categories are helpful, but not as helpful when we think about interventions. I'll also say that we see disparities like this for cardiovascular disease, HIV/AIDS, infant mortality, cancer screening and management, and other areas. So this has been our battle for the better part of 20 years, really trying to address disparities in some of these major conditions. I think it's been since 1998 a major effort as an initiative on healthy outcomes emerged right around that time out of the president's office. So this has been the work that we've been up to, and we've tried to make the case and help people understand why we see these disparities in health. And fundamentally, we like to talk about three areas in rank order that lead to racial ethnic disparities. The first among them being the social determinants. So you've heard a lot about social influences, social determinants, this idea that your genetic code is a better predictor of your life expectancy than your zip code, is a better predictor of your outcomes than your genetic code. But I think this year allowed us to go a little bit deeper. It allowed us to say that, yes, the social determinants, things like where you live, your socioeconomic status, your access to education, your access to fresh fruits and vegetables, play space and safe space, is really critical to your health outcomes. And certainly, we understand that minority populations are negatively impacted by the social determinants. For example, going back to diabetes, we know that individuals in communities of color are less likely to have access to fresh fruits and vegetables. And if they do, they cost more and they're less fresh. And they're less likely to have either the resources or time to be part of gyms or exercise formally, and maybe not live in environments where there aren't sidewalks, so exercising isn't easy, or live in environments where it's not safe to be outside during certain times of the day when they get off work to exercise. So these social factors, I think, play a very, very significant role. But I think the conversation we've been able to say is that people don't choose to live on the quote unquote other side of the tracks, that we have a history in this country of very deliberate policies that are all centered in structural racism that lead to residential segregation, transportation policy, other environmental policies that impact health outcomes in a variety of different ways. So whether it be redlining in mortgage lending, whether it be a history of where we put our highways and how they've broken up communities, whether it be sentencing, criminal sentencing for the same substance, but in two different forms used by two different socioeconomic groups, the classic instance being that of cocaine, crack versus powder, and how the sentencing was very, very different, and how that led to incredibly high incarceration rates for communities of color. These are all examples of the social determinants, but a deeper understanding of them is one that says, let's look at the historic impact of deliberate policies that have led to these social determinants that have then led to these very significant disparities in health and healthcare. The next area that we talk about quite a bit is access to care. We understand that no matter who you are or where you're from, if you are uninsured or underinsured, you are going to do less well. Minorities significantly less likely to have insurance than their white counterparts, not because they're not employed, the primary way upon which we get our health insurance through our employers, but because even when they are employed, they often are more likely to work in jobs that don't provide health care insurance in certain industries, also maybe working multiple part-time jobs. So social determinants, again, the largest cause, access to care, another large cause, and then healthcare, which is the work I do a lot of my, the area I do a lot of my work in, which is if you have two individuals who present to the healthcare system, all things being equal about them, except for the color of their skin, might they receive a different quality of care? That is the research that emerged in the late 1980s, early 1990s by some of our nation's top researchers in some of our nation's top journals that began to do studies carefully controlling for those usual suspects and looking at, for instance, if you had two people who presented to the emergency room with chest pain, the only thing being different about them is the color of their skin, might they have a different care pathway? And in fact, multiple studies, hundreds at that point in the late 1990s, beginning to show that minorities who presented to emergency rooms with chest pain significantly less likely to be referred for cardiac catheterization, angioplasty, bypass surgery, cardiology specialist care. Other studies that showed that if you had two patients, all things being equal about them except for the color of their skin, and you see that they're both on hemodialysis, they both have end-stage renal disease, minorities significantly less likely to be referred for the renal transplantation list than their white counterparts. And it's not because they didn't want to be on the list. And so we have countless examples. The last I'll end with is pain management in the emergency room for long bone fractures. A lot of research showing that if you have a white patient, a Latino patient, African-American patient, presenting to the emergency room with a fracture of their arm or fracture of their leg, minorities significantly less likely to get the same amount of pain medication for the same exact fracture as their white counterparts. And so, this research culminated in what is often referred to as one of the seminal efforts and studies on this topic, which is now almost 20 years old, the release of the Institute of Medicine, now the National Academies of Medicine report entitled Unequal Treatment, where a group of leaders in healthcare, myself included, had a chance to look at this research for the better part of 2 years as part of this Institute of Medicine committee and really leave no stone unturned, look at the peer-reviewed literature, testimony from providers, looking at data, focus groups, I think doing extensive work to identify, do disparities in health care exist? If so, why, and what could we do to address them? With the understanding that yes, we need to address the social determinants. Yes, We need to improve access to care. But yes, and also we need to make sure that we have equity within the four walls of the healthcare system. And so after 2 years of that study, we said, without a doubt, racial and ethnic disparities in healthcare exist in a wide range of healthcare settings, disease areas, and clinical services, even when you control for the usual suspects, socioeconomic status, insurance, and other factors. And we said there are many sources that contribute to these disparities. There's no one solution, no one suspect, no one solution. And so I just want to mention a couple of them now. First is navigation. It's difficult to navigate the system no matter who you are or where you're from. It is more difficult for communities of color for a lot of different reasons, whether it be language barriers, whether it be not having previous experience with the healthcare system. All those factors, I think, create challenges around navigation that impact all again, but disproportionately impact communities of color, leading to these disparities. One component and contributor. The second is communication. So plenty of research now has told us the importance of effective communication in the therapeutic relationship, how critical that is. And we have plenty of research to tell us that minorities, when they're seeing their healthcare providers, have tended to report at much greater rates that they haven't understood them, that they haven't felt like they've been listened to, and they've had questions that they haven't felt comfortable asking. And so clearly, if we care about addressing disparities, improving the healthcare system's ability, doctors, nurses, frontline staff's ability to communicate effectively across populations is absolutely essential. And I think an area that has gotten a lot of focus over the last few years. Another key area that we've talked a lot about is this concept, especially in the last year, of stereotyping. We've also heard the term subconscious bias, implicit bias, but the fundamental notion here is that we as caregivers are human beings. And not unlike any other human beings, we take information and we put it in our heads based on things we learn formally and informally. Our mind is always looking for shortcuts in those situations to help us be more effective and more efficient. That set of heuristics, that kind of pattern recognition that serves as a foundation for decision making is very, very helpful in many facets of our life. But when it comes to our interacting with people, those stereotypes, that pattern recognition, may have untoward consequences for individuals we're communicating with who are different than us. And in this case, we know that healthcare providers are much more likely to be majority, to be white than minority. Minorities now maybe about 7-8% of all healthcare providers in the country. So you would imagine, and research has demonstrated, that clearly we are susceptible to making assumptions about people based on things we see with our eyes, race, gender, and age in that order, even when we don't believe we do it, want to do it, or think we do it. And those stereotypes are activated the most in situations when we're stressed, under time constraints, or multitasking. The perfect storm for how implicit bias or stereotyping could play out and contribute to the disparities that I'm talking about, especially around clinical decisions where there is more subjectivity or discretion. So clearly, again, we found this in our work in unequal treatment. There's been a lot of studies that are very, I think, in a very crafty way, very sophisticated way, aim to use something that's out there that's very well known called the implicit association test, developed by researchers at Harvard, which is absolutely phenomenal. It allows us as human beings to, really identify subconscious biases and preferences that we have, and then connect that to clinical decisions. And fundamentally, we've seen that, yes, there is that connection. And I'll say that in the healthcare community, we have seen an evolution in thinking around our kind of understanding and acceptance of the fact that we stereotype. In the late 1990s, early 2000s, we surveyed doctors about, do they think bias impacts their clinical decision-making in any way? And at that time, about 99.9% of doctors said, no, not me, I don't do it. I treat all my patients the same. And I think it's because there was this false dichotomy of kind of racist yes or no, and not an understanding of how these factors could lead us to treat people differently, even when we didn't want to do it or didn't think we did it. And the good news is, through education around stereotyping and understanding the science, and I would say in many ways, really making people understand that it's not about good or bad people, it's just about wiring that could have very, very bad impact. Knowing that we still do have people, unfortunately, who are making bad decisions just in general. But that being said, we want to hope that in healthcare in particular, the overwhelming majority of caregivers want to do the right thing, helping them understand how them wanting to do the right thing could be informed by them better understanding their clinical decision making, and how stereotypes might impact that can go a long way. And we've seen that. We've made progress. In 2016, a large survey of over 16,000 doctors demonstrated that because of these efforts in medical education, now 43% of doctors now agree that they have biases that impact their clinical decision making. So progress is being made, but a major root cause there that we're trying to address. And then finally, mistrust. Understanding that trust, like communication, is essential to the therapeutic relationship. And if a patient is mistrustful of you, clearly they are much less likely to have a high quality encounter, follow your recommendations, take the things and follow the suggestions that we believe are important. And yes, we know that given our nation's history of racism, segregation, medical experimentation, and the like, communities of color are more likely to be mistrustful of their healthcare providers, even when they're meeting that healthcare provider for the first time. So it has been important for us in surveys as we looked at this, where minorities have identified, yes, I feel like I've been treated unfairly in the healthcare system based on my race and ethnicity, much more than their white counterparts. And they're more concerned about being treated unfairly in the future based on their race, ethnicity in the healthcare system. We need to do a better job of building trust in communities with patients every day. So this is the kind of playbook that we were following as we were trying to share these messages, which are as true 20 years ago as they are today. And we were also making the case that these variations in care and quality lead to inefficiencies, costly care, and poor health outcomes. And disparities are the epitome of low value care. So they are a high value target. Now, the IOM report on equal treatment gave us also a blueprint for how to address these, increasing the awareness of the existence of disparities, addressing systems of care by supporting race and ethnicity data collection, so we know who our patients are, measuring our performance in the care of our patients, evidence-based guidelines, multidisciplinary teams, community outreach, all essential components of efforts to address disparities and achieve equity. Workforce diversity, which I talked about. Large efforts now, certainly focusing more on workforce diversity, supplementing and supporting our work to address language barriers in the clinical encounter through interpretation services, educating providers around health disparities, cross-cultural care and communication, the impact of stereotyping on clinical decision-making, helping patients be more active in the clinical encounter, making them feel comfortable, giving them the tools to better navigate the clinical encounter, and then research, not just finding more problems, but figuring out what works, spreading and scaling that. And I would say that we were making progress. We were speaking to leaders in the C-suite, boards, hospitals, health plans, health centers, to talk about the link between disparities and equity and quality, safety, value to secure buy-in. We were talking about the importance of collecting data. Many organizations began to collect race, ethnicity, language, highest level of education of their patients, to then measure performance, to develop annual reports and dashboards. You have a screenshot of ours here at Mass General, where since 2007, we've had a disparities dashboard, then now an annual report on equity and healthcare quality, which is publicly available. You could Google it. We put it out every year. We just released our report for 2020 now that we're in 2021. So this is important to really put your money where your mouth is and say, yes, I deliver equitable care. We have probably 30, 40 organizations around the country that are doing that. Educating providers and staff. How do we make sure that we don't do one and dones with our education, that we really integrate education in these areas around racism, implicit bias, microaggressions, bystander, cross-cultural education into everything we do all the time for our entire careers. And we've seen the development of culturally competent interventions, coaching, navigation, the deployment of community health workers. This is all where we were, and these are the key lessons from the field, literally as of early 2020. Then 2020 happens, as you all know. What does that context lead us to? Two seminal events fundamentally changed the landscape of health equity. As I mentioned, the COVID-19 pandemic disproportionately impacting communities of color locally, nationally. And the story we tell is, this isn't that communities of color were more susceptible genetically to COVID. It's that the perfect storm of being the victims of structural racism, coming into the pandemic with disparities, more likely to be living in densely populated areas, multi-generational housing, to be essential workers and not have the luxury of working from home or having your groceries delivered, to be exposed in public transportation. All of those factors put communities of color at the epicenter of the pandemic. We were hit early, we were hit hard, and I think this became a key lesson for us locally and nationally. And then on the heels of that, the murder of George Floyd created a national reckoning on racism. So what did this lead to? What was the springboard here after we'd been doing all this work for years? These events highlighted like never before the impact of historical racism, structural racism, including in healthcare, the social determinants, and disparities in health and healthcare. And we attempted to both identify a series of key lessons and now leverage them going forward that lay the groundwork for creating a more just, equitable society and healthcare delivery system. And I would say that this time calls for meaningful change, executed with urgency, and breaking from previous norms that included unclear targets, limited accountability and resources, and aspiration but limited execution. And that is where we are now. And so I'm going to pivot to share with you some key lessons around COVID-19 and equity and structural racism. From the bird's eye view that I had over the last year, leading Mass General Brigham's equity and community health COVID-19 response with many, many people. So being a part of a broad team that led efforts in this space, and also having the privilege of being part of Mass General Brigham and Mass General Hospital's response to the murder of George Floyd and our national reckoning on racism, with two very significant efforts, United Against Racism and the MGH Structural Equity 10-Point Plan. So I was involved in the pandemic as a caregiver, in work related to community and work related to systems. I was able to touch all aspects of this. And so it's with a lot of passion and dedication, but with all due humility, that I share lessons that I believe have been important for us. Number one, we need to incorporate an equity analysis into emergency preparedness. In my view, we could have done a better job if we were thinking about equity going into the pandemic. History told us and tells us that man-made and natural disasters always disproportionately impact communities of color for a lot of different reasons. Hurricane Katrina being an obvious one, where individuals with lower socioeconomic status living in lower lying areas where levees weren't protected were disproportionately impacted. So, we have a long history. That's just one of many examples of this. So going forward, and in this case, we should have been able to say this is a virus that spreads with a 10-day asymptomatic period. People being exposed to each other in a variety of different ways are going to be at higher risk. What are the environments? What are the types of people that are more likely to be in that perfect storm? We need to do a better job of thinking ahead and incorporating an equity analysis into emergency preparedness. We pivoted as quickly as we could. I think we were able to connect the dots early in the pandemic, but we need to be more rigorous and deliberate around that in the future. As I mentioned, communities of color hit early, hit hard, and we're in this perfect storm. Number two, we need to incorporate race, ethnicity, and equity measurement in all we do. So we stood up a variety of different efforts to address what we saw with COVID, particularly the fact that here at MGH, 40% of our COVID positive patients in the first surge early on were Hispanic Latino. And so if we didn't have that data, we wouldn't be able to understand who was being impacted, sound an alarm at the community level, and take steps here at MGH to make sure that we were meeting the needs of our Spanish-speaking patients. So surveillance, monitoring, dashboards, and reports that serve as a springboard for action need to incorporate race, ethnicity, language, and other socio-demographic characteristics if we are to assure equity. Number three, as we redeploy for emergencies, language is an asset. We are a diverse nation. We speak multiple languages. And fundamentally, in emergencies, assessing people who are deploying to address the needs of those emergencies, assessing people's language capacity, and then using their language capacities as an asset is incredibly important and something we should do in the future. So here at Mass General, we were able to do that. And at Mass General Brigham, by literally putting a call out to help us identify individuals who spoke different languages. We created something here at Mass General called the Spanish Language Care Group. We put out a call to doctors who spoke Spanish, identified 50 from 15 different Latin American countries, from 15 different disciplines, who we were able to mobilize 24/7 to work shoulder to shoulder with our surge teams in-house caring for our COVID patients, bringing clinical, cultural, and linguistic competence to those efforts. If we didn't have that information, if we didn't have the information about the language needs of our patients, despite having great interpreters, we would not have been able to connect supply with the unnecessary demand we had. And so we've been able to leverage those trusted messengers to deliver messages on everything from the surge to staying healthy, to coming back for care, to the second surge, to vaccination. Diversity is critical, and it's not just a nice to do. In the pandemic, we demonstrated it was a need to do. It was mission critical. Lesson 4, as we evolve clinical care, we need to assure equity. So we built in, as part of our COVID response, multilingual hotlines, patient information in multiple languages, and addressing disabilities. Virtual health, we made sure that we weren't just doing things for people who are well connected through things like Zoom, but also just using the good old-fashioned telephone and doing telemedicine. We need to make sure that we get people enrolled in the electronic health record as we use that as the key kind of connector. So we need to assure equity in everything we do. And it can't be an afterthought. It needs to be a current thought. And we're trying to develop the discipline so that in anything we do, we say, how will what you are designing meet the needs of everyone, not just a select few? And going through that equity discernment, that's going to be critical. Lesson 5, we need to care for those within our worlds, and communication is key. By that, I mean, we know that certain communities were hit hard by COVID, and we have many of our employees in services, such as food and nutrition, materials management, environmental services, who live in some of those same communities and who are in our midst. We help our communities by helping those who live and work side by side with us here. And so democratizing information, making sure that as we send information about emergencies, that it comes out in multiple languages. It doesn't just come out in email, that we use texting and an emergency text messaging platform that we launched. Democratizing information and understanding that as we think about community health, we have individuals from those same communities in our midst, and we could do a lot to help them and help them help their communities by leveraging them as ambassadors. I think this is a real important pivot for us as we think about the future. Lesson 6, the social determinants of health, which are bad on a normal day for communities of color, will always worsen in the case of disasters. And in this case, hasten spread. So community health needs to take a doorstep to bedside approach. It's not just about ventilators and bed capacity. It is about putting out the fire, the spread of COVID in communities, so as to maintain capacity. And we cannot turn a blind eye to public health and community health inside the four walls of our healthcare system. And then finally, we must have equity in all efforts. So I've called out a couple of efforts where we need to incorporate equity, but there are certainly many, many more. And developing that culture, that discipline for us as healthcare systems is really where we need to be headed in the future. I'm now going to pivot to lessons from what I call our national reckoning on race and our need for structural equity. Lesson 1, structural racism is deeply embedded in healthcare. There's no doubt about that. We have not had these conversations. We have not looked for it. It is invisible to many, acutely painful to many as well. So certainly we need to take action to look at clinical policies, HR policies, clinical guidelines, to identify where, if, and how structural racism is embedded and address it and remove it. So that is a key lesson and something that I think organizations should be committed to. Lesson 2, we as caregivers need to feel cared for. Our minority caregivers and our minority workforce experiences daily transgressions based on their race every day, from overt racism from patients to microaggressions from colleagues. That it spans the entire gamut. But ultimately, we need to understand that developing a mechanism to really live our values, to be able to report and reconcile these situations when they occur in a trusting way, is absolutely essential. Lesson 3, there's little understanding of national and local history as it relates to healthcare. We need to do a better job to train ourselves, to learn about the impact of racism on health and healthcare, on our society, in our communities. And we shouldn't just do this for those who want to do it. It's important learning for everyone who is engaged in these efforts in healthcare. So it needs to be mandatory, customized, but it is needed. Disparities in health access and healthcare persist. No doubt we need to bring resources and rigor to this work like never before. Lesson 5, inequality is a health problem. So ultimately, things like living wage, educational advancement, access to care, social needs are a shared issue. And we need to raise our voices in healthcare in support of addressing these challenges and avoid them from being so politicized and come up with common sense solutions that are practical and that move the needle. Lesson 6, on diversity, we are not missing by a little, we are missing by a lot. We need the courage to make commitments and execute on a diversity strategy as we do elsewhere with real targets and goals and plans and accountability. And then finally, we need to communicate what we stand for and advocate for it. So I now want to turn to how we, particularly in this last area at Mass General, have taken these lessons and built a plan to address all these lessons and these needs. And again, I would say that these are completely in sync with a much broader and larger plan as part of Mass General Brigham's United Against Racism. This is a synergistic and supplemental effort to that effort here that's locally designed, the MGH Structural Equity 10-point plan. I'm going to walk through quickly all 10 points and give you a flavor of the way we are addressing these challenges. And I will say that this effort was launched in November. It has been resourced with tens of millions of dollars. It brings to each point goals, key activities, timeline, milestones, accountability, transparency plan, all of it, resources needed. So this is unprecedented rigor. This is a comprehensive, ambitious plan. And now the challenge is to execute on it. So I'm going to walk through each one of these. First, policy and practice review to identify and reconcile structural racism. We are reviewing all of our clinical policies with Mass General Brigham, our HR policies to identify and reconcile any place where structural racism is evident. Number 2, we are developing a reporting and reconciliation plan for incidents of discrimination and racism, where they occur patient to caregiver, caregiver to caregiver, caregiver to patient. We need to be able to have a reporting system that works for all and a reconciliation plan that works for all. And we are doing this in collaboration with Mass General Brigham. Initiative 3, developing a training pathway on racism and associated factors. So yes, we need to and will be building out a training pathway that is mandatory for all, that creates a long-standing learning pathway on these factors in collaboration with Mass General Brigham. And they include things like racism, microaggressions, implicit bias, bystander training as just some. But this isn't a short-term, one-time, and one and done. This is a long-term pathway for the future. Number 4, assure equity and access to and delivery of clinical care. We are launching an unprecedented effort that centers equity across the entire care journey of the patient, from their doorstep in the community to our doorstep and the bedside, in our ambulatory settings, inpatient settings, post-acute care, and back home. So we are looking at our emergency department, specialty care, inpatient, post-acute, the entire care journey from your doorstep to the bedside and back to your doorstep, and centering equity there in experience, quality, safety, in all of these areas, as well as launching signature clinical initiatives that are now underway with the new sickle cell disease treatment center and the new effort on equity in clinical and renal transplantation. Initiative 5 is eliminating racialized science in medicine. This is taking race out of clinical guidelines when it is there inappropriately and not on a strong foundation of science. So whether it be the race correction for EGFR for renal function, whether it be race and pulmonary function tests, or any of a myriad of clinical guidelines, we are going through that process of reviewing any case where race is embedded into a clinical guideline, assessing it, giving it due process, and removing it if it's there inappropriately. This is complicated. Race is a social construct, and so we need to be diligent about this and think about in the future too its impact on artificial intelligence, clinical decision support tools, and the like. Initiative 6, assuring a living wage, educational development, access to care. Like Initiative 5, Initiative 6 is working with Mass General Brigham to think about ways in which we could be supportive for all of our organization, including those who are the lower wage earners and the more diverse amongst us in our organizations. Initiative 7, committing to diversity and equal representation like never before. From the boardroom all the way across the organization, we are committed to doing a better job around diversity and bringing more rigor to that work, and are excited about that potential. Again, unprecedented resources and accountability built into these efforts. Initiative 8, assuring an environment of safety, equity, and trust in security. So we need to also work with our police and security to make sure that we are certainly a safe and equitable environment for all. And this is an exciting area, a great partnership, great leadership from our police and security leaders, and we'll be evolving that work as well. Initiative 9, deploying an equity, anti-racism, and inclusion campaign. This is an effort to assure that people see themselves here on campus, feel welcome, feel included through arts, literature, music, space, all things that are critical. That is Initiative 9. And Initiative 10 is engaging and investing in an anti-racism advocacy agenda so that we raise our voices against racism, not just in healthcare, but in all facets of our society. So it's with that I want to thank you so much for your time today. I hope this was helpful in articulating both key lessons learned from the front line in our work with COVID-19, in our work in our reconciliation of structural racism, in our plans going forward. The hard work is ahead. Your partnership will be needed. And I thank you so much for your attention and your commitment to this work. And again, hope that some of the things I've shared have been helpful as you engage in this journey with us. Thank you all so much.
As a closing reminder, attendees may obtain continuing education credits for today's session. To do so, please click on the link in the description below this video window to complete the evaluation and obtain the credits. This information will also be distributed through a separate email to today's participants. Along with links to a recorded version of today's discussion and credit information, the email will also include additional HMS COVID-19 resources. Please distribute to colleagues whom you feel would benefit from this information. Thank you again for joining us in today's discussion.